Good evening, everybody, and thank you for allowing me to speak today on my systematic review on synoptic operative reporting. I have no disclosures. So most of us have seen that quality improvement has become an increasingly prominent focus in healthcare, and this is often measured by means of established quality indicators in one of either structure, process, or outcomes. For surgical patients, the operative report is an essential quality indicator because it documents the processes of care that occur in the operating room. Most of us are all too familiar with the dictated narrative operative report, which is the traditional format in which the surgeon delineates the operative indications as well as the details of the procedure in a document that serves not only to coordinate patient care, but is also an important document for research, billing, and medical legal purposes. However, more recent data has suggested that the overall quality of these reports is quite poor. So why does this matter? Well, important surgical and anatomical details contained within the report can actually be very essential to the diagnosis and subsequent management of perioperative complications, as well as planning of subsequent procedures and investigations. So thus, the operative report is an essential document that has the potential to significantly impact patient care. So this has led to the rise in the development of synoptic operative reporting, which for those not familiar is a computerized template-based report usually, and has been suggested to be superior to narrative reporting in terms of completeness and timeliness. However, most of the evidence supporting synoptic reporting is based on small studies, many of which are entirely retrospective in nature, and no comprehensive review has ever been published on this topic. So we set out to perform a systematic review and meta-analysis of synoptic versus narrative reporting for any patient undergoing a surgical procedure. So we used methodology set out by the Cochrane guidelines to systematically review the literature based out of 6 main databases. And we used a combination of controlled vocabulary and keyword queries to identify all studies that compared synoptic versus narrative operative reporting. We then performed forward and backward searches on all included studies, as well as hand searches of included studies reference lists. And most importantly, we did not limit our search to language, status of publication, or publication date. 2 independent reviewers performed the literature review and subsequently performed the data abstraction, and all included studies had a methodological quality analysis performed using Newcastle-Ottawa scales. For our meta-analysis, all pooled continuous data was expressed as a standardized mean difference with 95% confidence intervals using a random effects model, and those outcomes not able to be meta-analyzed were reported by narrative description. So for our primary outcome, we looked at completeness, being a percentage completeness score of predetermined items felt pertinent to the evaluated procedure. And secondary outcomes of interest were reliability as a measure of consistency, efficiency, quality excluding completeness, obviously, and cost. So for our results, out of just over 1,600 titles identified, we reviewed 35 in full text and 16 met final inclusion. The methodological quality analysis showed a mean Newcastle-Ottawa score of 7.06 out of 9, suggesting a moderate to high quality of the included papers. Our primary outcome of interest showed that synoptic operative reports were significantly more complete than narrative operative reports with a standardized mean difference of 1.70. So just to put that into context, that suggests a large interventional effect. This is reflected here as well, where you can see in our forest plot that this heavily favors synoptic operative reporting. And I would like to draw your attention here also to our heterogeneity score of 98%, which is extremely high. So multiple subgroup analyses were then performed to try and identify the source of the heterogeneity. Unfortunately, we weren't able to identify where this came from. However, we did find that when we pulled out the 3 studies showing the strongest interventional effect, that dropped our heterogeneity score to a very acceptable 67%. And most importantly, our pooled effect remained strongly positive despite that. So we then performed a funnel plot to evaluate for publication bias of our included studies, and it did show, unfortunately, that there is a significant risk of publication bias. So this should look like a balanced inverted funnel, and you can see it's balanced more on one side. For secondary outcomes, we were able to meta-analyze time to complete the operative report itself. And this shows that, again, it favors the synoptic reporting with a standardized mean difference of minus 0.86. All other secondary outcomes were not able to be meta-analyzed. However, all of them trended towards favoring synoptic reporting. So in summary, the current state of operative reporting is somewhat concerning, and this is despite a couple of decades worth of interventions suggested, none of which have ever been able to show any sustained results. So this has led to the development of synoptic reporting, which in our review has been shown to be superior in terms of completeness, as well as some time efficiency measures, and has trended towards increased reliability, quality, and cost. So where does that take us now? So it seems intuitive that if you improve the quality of operative reporting, of operative communication and documentation, that should translate to improved patient outcomes. However, the data on this is significantly lacking. And that's likely because, well, this is a very difficult question to answer. One is, how do you measure that? Well, one potential option for that would be to, because of the computerized format of synoptic reporting, it would lend itself to real-time data collection and linking that with an outcomes database such as NSQIP could be one potential way to answer that question. Other questions of interest would be to look at more user-oriented quality analyses, as synoptic reports have come under some fire for their readability especially, and I think a more comprehensive evaluation of cost would be beneficial. I'd like to acknowledge my co-investigators and especially my supervisor, Dr. Ashley Vergas, who couldn't be here today, for their support with this study. Thank you for listening, and I welcome any questions.